Dheeraj Khatore, a dynamic professional with over 10 years of experience in healthcare quality, EMS and ambulance auditing. He has a diverse background serving as a healthcare quality auditor, international business operations expert and HEMS paramedic. As an entrepreneur, he has explored areas such as medical training, healthcare, AI, digital health and EMS consultations across UAE, USA and India. With a master's in healthcare management and a specialization in AI in healthcare, along with a certificate in digital health from IIM, Dheeraj is driving innovation in the intersection of healthcare and technology.
Thank you very much for that. I hope you can hear me clearly. Okay, so great. So I represent AACI, which is American Accreditation Commission International, purely a new body in India. And that is what I am doing for the last 2 years. So you saw my journey. I am very proud to be a nurse, so I'm still not a doctor. So just to say about that, so I am from Kozhikode, and after my nursing, I finished to get back to EMS, and then from the quality and now AI and digital health, and sort of what we are doing right now. I'll be taking around 40-45 minutes, so please hang on with me. If you are sleepy, let me know. So the session is very much important with related to the safety week which we are doing, especially with regards to the quality in healthcare. And when we talk about NABH, which proudly I say is one of the forces that have changed India, where I see the practices at least coming to some sort of standardization, but still, of course, there is flaws for every system. And that is where AACI pitched up to be the next level opportunity for Indian hospitals. We are ISCO accredited, 10 years in service from US, and I handle India and Africa operations. So we are equal to JCI, which is the name that you would have heard about it. But I'm sure most of them don't know AACI. So we are still new, but we are fast enough to catch up the speed that Indian market needs. So let's move on to what we want to discuss here. So our mission and vision is a bit different from what we see normally. So we consider ourselves as a third eye, which you have never seen on identifying risk and saving lives. Our standards are written in every chapter. We have a risk process involved. And the first 2-3 slides, I'll be discussing about how AACI Approach works, what difference we bring, and why it is not that easy to run it, but it is easy to adopt it. So it's all about adoption. People run away from adoption, but that is what we make sure that you adopt it. But to run the show, it's not easy, but we should be expert in every field that we are bringing. If you see, our vision is mitigation of human error in healthcare. So the first slide Lalu ma'am said about is the medical errors, right? We are going to be having all the different tools. We can bring AI, we can bring whatever it is, but we still make mistakes for sure. We are humans. But what we can do with our standards is we can mitigate it, means we can try to bring it down, and that is where we actually come in. So next couple of slides are a little bit of theoretical setup. Why I put this one is to understand what is difference from what the accreditations you have seen right now and your experience looks like, and what is AACI actually does. And this is where if you understand these two approaches, then it's easy to understand what I'm really talking about patient safety systems. So our methodology is a backbone of an ISO approach, and that is where we bring the concept that we just don't give you a accreditation and run away. We come every year. Means we want to be seen that our healthcare provider is changing, and change takes time. So it's not that we just give you a certificate and thank you very much, see you after 3 years. If you accredit with us, we come every year and in the same time. So we are a seasonal guy. So make sure that if at all you jump on AACI, you get to see us every year. That means we want things to change. So it's not just, you know, identifying and giving you the certificate that you cross this specific percentage, but we want to see what's happening this year to next year so that you maintain the quality of accreditation as well as patient safety. So this is a little bit theoretical. Usually I don't put these slides except they're paid for us for the joining the course. But I thought I will just give you an idea of what do you mean by process approach. I was glad enough to see Dr. Allu already pitched it a little bit up. So where we move around is about process approach. So what we consider is no two hospital is same, okay? We are a global organization, 350 accreditations all over the world, and we know that copy-paste won't work. So you cannot copy US to Europe, Europe to Middle East, Middle East to India, India to Africa, and any other countries. You agree that, right? What about India is so diverse with different states and languages? We cannot copy one corporate to next corporate. And that is what has been done. When a copy-paste mechanism starts, the things will not change on the ground. For us, we don't need a copy-paste. We ask you, what is your process? What is KIMS Alshifa's process? Show us that you don't need to change everything because we are going AACI. Okay, so our methodology starts from a series of events. So what is process? You work in different areas. You work as nurse, you work as facility management, whatever is your domain. Do you have a process? Everybody has a process, right? We put something inside, that is what the input. So I'm not a politician to say what's going to come output. But you understand, there's an input and there's an output, which can be a patient, a service, a process, a product, anything. But the in-between thing is the one which makes difference, which is the process. And this is where we go always wrong. Okay? We have a good input mechanisms maybe coming up. We are expecting a very good output using a checklist. And this is where my second point comes in. AACI does not have a checklist. So don't mail us and ask, sir, please send me a checklist. I will say, thank you very much. Go and read the book, 130 pages. That's it. So why we don't have a checklist? Because you will still become the checking guy. And we don't just come and check you just by checking something out. We want to understand what is your process. So sir was asking about HR. So we interview HR, we check the document. What is your process? So your policy, so your methodology, how do you work? And then you will see there is a difference from what you have written and what you practice. And opposite, you practice a lot of things, but it's not written anywhere. That's the gap, okay? So what a surveyor in AACI does is we come and check you what you have been doing with your own things that you have established over years of experience. So as the management change, people change, process do change, we understand. It's not static. It's a dynamic thing that keeps changing. And that's why we need to come every year. Because last year the quality manager was somebody else. This year is somebody else. Nursing officer is somebody else. Why? Because attrition is going to happen. You cannot stop it. But what about the patient? Patient safety cannot change just because we are changing management. It should be stabilized. We can depend on the tools. We can depend on technology. But if you don't know the process approach, you are basically doing a checklist. And checklist cannot change the patient outcome. Okay? So this is where we come with the input process and process approach concept. Where we want to make sure that whatever you learn from your output come back to the process, and process needs to be changed. How many times you have accreditation coming and you just change the policy number? Do you agree with me? Just change the policy number, version number, date is good, everything done. You cannot play with that with us. We will show your policy. What did you change this year? That's the only question I will ask. And if you say nothing, thank you, it's an NC. Because if you didn't change anything, means you are not working. You are not putting back the thing that you want to change, right? So you got an output. From that output, it has come back as an input and process change. Then only you will improve. And I cannot tell you what you should be improving. Don't expect AACI to give you lessons about how you should be doing. You should your own. This is what we approach is, you have the entire entity that you work on your standards, whether your process match to us. So when we say international accreditation, what does it mean? I will get a similar care if I go to some other country. This is what we are expecting, international standards. It's not just about buildings. Okay, some people have that, I made a 5-star building, I will get accredited. Sorry, it cannot happen. If you have people who doesn't understand anything inside, you won't get accredited, even if you have a best building in the world, best clinicians in the world, but they are not doing the job what we want. So this is where I want to make sure that, how is AACI approach? It is to hospital, you design it, we evaluate whether you match to our standards. Next is the important, which people don't understand why we are putting this. Risk-based approach. Risk-based approach is nothing but, do you identify the risk in each type of process that you have designed? Most of the times we are not remembering what's the risk, or we don't identify it. And that's why you need accreditation people to come in and tell, this is a risk, you have never identified this one. So inherent risk, I'm sure anybody entering to the hospital has a lot of inherent risk, which is starting from infection control to death or medication error, anything that is always there. That's the biggest part of any risk activity that you do. The second and the third one is something different that you can work on, which we call control risk to detection risk. Control risks example ma'am gave in the morning, that if you have a medical record, which is handwritten, there's always a risk involved with that. But as you automate, as you bring something which is controlling that process, can be a checklist, can be, but checklist should be filled correctly at the right point at the right time, but can be a technology. Automatically your control risk comes down. So any ill-defined process in your hospital, can be food and beverage, can be radiology, anything has a control risk which you can bring down just by doing automation. And that is where you take care of the patient safety part. Detection risk is something which is very important, which people don't understand. Why ma'am was telling that give different standards to the people who own that standard, because they know what is the problem in that. This is end user concept. Okay, I cannot go and survey 30 standards. I can survey only 10 standards because I am expert in that. If I start jumping to doctor standard and if I start jumping to air condition, I cannot deliver the best. I can do something, but I cannot deliver my best. So I'm not doing ethical practice, right? I'm coming here 3 days, you're calling us, and if I start jumping on the standards and keep doing everything, telling that I am expert, I have worked so many years, and I am blah, 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 it doesn't work for us. We have experts who come only on those specific standards, who know in and out of it. And then we also start learning, seeing different hospitals. So that is detection risk. Suppose you want to go to the biomedical and you want to do a survey or an audit. You take the biomedical guy with you because he knows better than anything else. That's simple. It's not the quality people can know everything. So usually when we say accreditation, it goes to the quality head. Let quality run whatever the show they want. That's not quality. You need to give it to end user. So I have 5 cases which is picked up for patient safety. And that is where we will discuss, like, it is end user business. It's not just quality business. Quality has to have an oversight. They should know what's happening. Leaders should know what is happening. But they are not going to implement on the ground. It's the end user. So shall we move on risk-based thinking? So this is a little bit theoretical because I just wanted you to understand what is different from what you have seen right now, what you have been doing for years. You cannot be doing the same. You should go to the next level. And that is where flexibility comes. We are flexible. We allow you to develop your own process. We don't ask you to do the same way that we want. Okay? So this is our standards. It looks like 30 standards in different sections. As I said, first 10 standards are governance, which is what I do. Quality background, leadership, risk management, nursing, medical staff, and all of those things. Module 2 is patient focused, which is only clinicians. Again, not any clinician plus MD plus he has worked in quality. So the people that we select is tough. I get 100 plus application every day to become a surveyor. And imagine India is how big. Everybody wants to pursue something different. But I have how many surveyors in India, if anybody can guess? Anybody can guess how many surveyors I have? I'm operating 2 years in India. How many surveyors, external surveyors I have? Any guess? Any numbers? Imagine NABH may have 1,000 people, right? At least. How many AACI has? 20. Any more guess? How many AACI surveyors, one is me, of course. What else? How many we have? We have 6. 6 means, not everybody is IAS, right? The same concept. Not everybody get into external survey because that's the vetting procedure I put. I vet them for, most importantly, do they know their own area of expertise. I have only one engineer who is doing the module 3 completely from the entire India. I am not able to get the right person who can run the standards in ancillary services. Can you imagine? That is what we are under trying. And all of our AACI, we have only 6 engineers who work with module number 3. So the people we are bringing is not just from anywhere. We want to expand. We want to do so many things, but we should not take off our quality, what we are delivering. And that is where putting the first pool is important. But we train a lot of internal surveyors. We have around 180 internal surveyors which can run the business on the ground. So that's the difference. We train people, we train quality. Anybody can join the course with me, become an internal surveyor certified, know the 30 standards, implement in your hospital. That is what going to change, not 3 days of my visit. My 3 days of visit is just to give you what you're doing right now. But can I sit with Sir Khalil and say, do it? No. That do it has to come from Swati, right? That means they should be knowing what internal survey means. You should have quality coming from your own part, not from an external surveyor. Just to give you, because people start working after an accreditation report. They get 55, okay, let's work, close it up, 70, good, we got a certificate. That's not AACI. You cannot survive with that because we are going to come next year again. What you will show to us? You need to show changes, otherwise you are still not getting accredited. So to maintain accreditation is very important, as similar as getting accredited. So I'm not telling we are tough, but we are doing the right job, that's it. So the topic is patient care, patient safety, and I will put you on the standards. So one of our standard is patient safety system, and it comes under governance. Means the governance is the quality people who is doing this accreditation part of it. It's known as patient safety systems. So it's chapter number 6, so we call standard number 6. We can share you the standard if somebody is interested. If you see, there are 3 parts of it: the general, the traceability, and opioid oversight and use committee. I'm going to pick up something which is not at all done, or maybe done for the regulatory authorities, but how that impact the patient, and that is what we call traceability. So coming to the traceability, before we need to know the patient safety systems, which is already discussed. The first one was the medical errors, right? So I'm not going to go back to the medical errors. Communication, Dr. Yellu already explained that part, so I'm not going to come back again on that. So I don't know, we have a matching without having a knowledge what she's going to speak, but at least she covered that point. I will be speaking something on opioid oversight and how our annual patient safety goals are assigned, okay? So traceability, has anybody heard about traceability from the group? I just cannot keep talking on my own. That's my problem. If you have mics to give to the people, we can have an engaging session. Otherwise, I just keep saying everything. Somebody can give mics to the people around? Anybody can tell me what is traceability, or give me one example of traceability. I'm sure traceability is already in place in this hospital because of a regulatory requirement. But anybody in the audience can tell me what do you mean by traceability? Traceability, come on. No idea about traceability? No, so, okay, so this should not be last class. Okay, let me go back to that. So traceability is nothing but how do you trace back to the patient what you used on somebody, okay? I have used a medical equipment. I have used a knife on one patient. I have used a sterilized equipment on a patient. Can I trace it back to the patient after 1 year, after 10 years? Do we have that process? May not be. How do I know which anesthesia machine I used? Which ventilator I am using on which patient? It's not to do with ventilator. It's all about traceability. Is if it goes wrong, can you reach back to the patient? And that is where traceability standards comes in. Endoscopes. We have seen hospitals using the endoscopes with very minute way of not identifying separately. There are 10 endoscopes. We don't know which one was used for which patient. They say it was safe, it was doing the decontamination, but there is no documented evidence that I can tell that my endoscope was not the same endoscope you used for 5 minutes before. And that is where patient safety comes. It's still a evolving concept. As I said, this is one of those part of the standards. It's not much done in India. We get NCs by closing our eyes because we know this is happening. And that is where we have an example. Okay, let's put in a scenario over here. Everybody knows CSSD, right? And everybody use CSSD equipment. And surgery is the one of the best area that we should be there. If you have a failure in CSSD, the hospital is closed. So what we have a background. So we have an operating room which is handling all of these different type of devices. I am especially interested on single-use device in India, SUD, right? Single-use device is only for SUD. I mean, it's only single, but we use multiple. Do you agree? Yes. AACI allows that, but you come in Middle East, we will not allow that because country law says you cannot do it. But in India, we allow it because we want the standards to be used as per the country law. Single-use device has been multiply going through the sterilization process. How risky it is, this is where traceability comes. So can you trace the type of equipments you are using in your operation theater, your cath lab, your dental, your laser, different areas. You are using so many of those equipments which cannot be even coming second time, but you are allowed to use. But how do I track to which patient it was used? There's no methodology with me, and that is where traceability comes. So what is the incident? We have sudden spike in surgical site infections, and now the infection control is telling that we need to do a root cause analysis and identify where this infection is coming from, okay? And that is where the importance of traceability comes. Some people say this is impossible to do, but I'm sure it is possible to do. That's why we are here, okay? So you need to change yourself. You bring your ideas to do it, and hospitals have done it. First time they were not dying much, but then when the NC came up, they brought the ways that how do I fix traceability in my hospital, because every hospital is different. So how do we implement AACI standards on traceability? Tracking instrument use. We can track the entire cycle of the instruments used. Usually CSSD is working on their own, and they don't have a connection with the end user. Means operations theater does not know what the CSSD guys are doing, and there's the same thing coming. How do you track the same equipment in different departments? And that is where traceability comes. And eventually to the medical record of the patient. That is where we end. You can see how the CSSD cycle monitoring works. And if at all there is an investigation, there are a lot of equipments goes in the same cycle. And suppose we have 10 equipment in the same cycle, that 10 equipments were going to 10 different patients. Are you getting? And then we need to track that 10 different patients whether they got the same problem. If you don't have traceability, you cannot do it. And that is where we have a disconnection. And this is where we brought it that you have to understand the traceability as much you can so that you can fix this problem. So this has been proven worldwide that there is no traceability in so many areas. In some areas there is traceability. My question still remains open. Who can give me an answer that there's a best traceability in one of those areas of the hospital which you do it for regulatory requirement? Regulatory requirement wants you to trace in and out of that, and every hospital is doing that. So come back to me with answers if you understand what I'm talking about traceability. Patient safety and reporters. You have to report back to the patient that there is an error happened from the hospital. Okay, so if you don't do that, you're not doing patient safety. Basically, you're just running your business and thank you very much. But if you don't go back to them, it's your mistake or something happened, you need to report it back. And that's how you improve your compliance. Every time we identify traceability issues, the leadership comes and tell you that we never thought about this. And there is a huge chance of error because we don't have traceability. So any endoscopes putting in my mouth can go to the next patient, and it can be the one which is transmitting all the infections, and you know what all of the infection that comes with endoscopes. And that is where the traceability was so important. So benefits of having traceability. You can have a detailed tracking. It is difficult, but it has to be done. And if something goes wrong, you can track the entire people who has been using that cycle so that you can fix the problem or at least check whether something is going on. Remember, regulatory compliance. Anybody in the group can still answer my question. There is a regulatory compliance in one of the things that we use in the hospital which has a exclusive traceability. It is traced in and out. What is that? Because of regulation, we have an excellent traceability. Which department or what is that we use that has an excellent traceability? From the point of origin of where it is taken, how did it move, which patient got it? Correct, blood transfusion. Implants. Can you see now? We are already using it, but we are not putting our brain over there. That's the only problem. Blood transfusion, go and check in and out. You can see that where the blood came from, even the platelets was for whom, the whole blood was for whom, or something else is for whom. You know, even the divisions, we know which patient got what. And that is where traceability comes. And where we put the risk is, suppose you have an in-house blood bank, you are good. You have full traceability. Some hospitals doesn't have in-house. They bring it from outside. There is always a gap from something come from outside because it's outsourced. There is where you have a legal risk. Remember I told the process approach on risk. And that is where we identified blood coming from outside has no traceability. And there is the legal risk for the hospital. So hope you understand how AACI works now. So can you see where all traceability comes? I actually split the two slides. We have given a list here. Anesthesia, ventilator, endoscopes, decontamination, SCUD, single-use device. And we have a list here in that. Critical equipment For example, if you have brachytherapies and if it is not automated, ionizing radiations, vaccination, do you want vaccination to be traced? Yes or no? Yes, we already had a COVID problem, right? After the COVID, they wanted to be traced the back. How many kids are getting vaccine, but the card is with the parents? Hospital doesn't have a data, except pharmacy has some data, just they gave this medicine. But there is no full traceability on that. Blood transfusion, I said, regulatory and pharmacy product. Anywhere we see that the hospital has been using some sort of equipment where manufacturer want you to trace, that is where implants comes. Okay, so traceability is patient safety for us. I hope you got the point. Let's go to the second scenario. Managing opioid prescriptions in hospital. So we have a therapeutic committee on patient medication, right? Do we have a committee on medications? And most of the time, that is the only committee we have for the medications. AACI wants you to have another committee, which is opioid committee, because that is the risk that we have identified for the patient. So scenario, we have a tertiary healthcare hospital, chronic patients are getting a opioid, and the patient is coming back to the emergency department with signs of opioid dependency. Okay, because patient is taking so many tablets and now they are dependent on that. Who is going to trace this? It's not about tracing. Who is going to look onto the opioid prescriptions? Who is going to check how many opioids were given to the patient? And that is again a patient safety. I have a live example of having the same thing happened in Abu Dhabi. One lady was going to the everyday different emergency department, getting a shot of tramadol. Every day she goes to different department getting a shot of tramadol. We don't have an ability to check that why this patient is going. And she developed so much of resistance. One hospital did one of the worst things they did. They blocked her in the EMR. Means that patient comes, she cannot register it. It became a legal issue. We went and investigated. That was my job. And then we identified that this patient is doing these rounds to get this drug every day. It's a lady. And this is where the patient had the problem that I'm not getting a right to admit to the hospital. For example, the same patient came with a trauma. You will not admit her. You need to admit her, right? After that, you won't believe it, Abu Dhabi Department of Health started an entire pharmacovigilance that you can track. If I give opioid here, tomorrow morning they go to MIMS, it will pop up in MIMS that this patient got an opioid. That is what Abu Dhabi did. It's technology, of course, we cannot do that. But can you do in your own hospital? Yes. Can you track your own hospital this patient is getting? That's where opioid comes in. So establish an opioid committee is important. Who uses the maximum opioid? Maximum in the hospital. Who is using? Anesthesia. So give it to them. I'm sure they will be happy to have this committee because they are doing a lot of things. The leadership is not seeing that. Quality is not seeing that. They're doing a lot of documentation which matches to the opioid committee internationally because of anesthesia practice. So give them that. This is the committee we want. Physicians, pharmacists, nurses. So it's just not about filling the form for the procurement, the E3 form, what you call. It's just not that. That is only one cycle or one part of the getting an opioid. We are looking more beyond that. Do you evaluate the patient risk of getting this opioid? Do you have patient control analgesia? What is your protocol on opioids? Whether you send opioids to home? Who is monitoring the patients who is on home opioids? Okay. How do you do handover? How do you do education, documentation of opioids? This is the biggest problem in Western world, and I'm sure it's coming to India already, but we never check it. Okay, we have a system that we cannot give more, or we have a good control on procurement, but that doesn't mean that it's already given. It can be given how you want. That is where the opioid is required. So what happened to this patient? They did an investigation. They understood that they have missed the steps, and that's the reason the patient went for an opioid dependency, and now she's on another complication which needs to be taken care. So if at all the patient is on opioids, they should be having a committee to understand what you are using. Again, you can develop your committee, you can put your points, but it should match to our standards. So that is second patient safety that we bring is an opioid committee. So I'm just putting what is not done normally. I'm sure you are doing for NABH and other things. So structured oversight, because you have an opioid committee now. Patient is safe because he's not getting something which is beyond. And now the patient knows we have a data of the patients who is getting opioids, and that improves the outcome. The third one is AACI patient safety goals. Are you aware of IPSG goals? Great. Whether it changes every year? No. come to AACI, we change our patient safety goal every 2 years. Why? I cannot have a goal which is 1983's problem, right? So patient safety goals has to be changed, and AACI have a methodology to have new goals depending on the trends of what is going on all around the world, and depending on the studies and outcomes, we change our patient safety goals. And that is nobody is doing in the world right now. So one of the goals which again is impacting, and I was talking this yesterday with the technology conference, is awareness and prevention of burnout in staffing. So burnout is a big issue which is actually affecting patients. It happened in COVID, of course, very huge burnout, but it is continuing, and that's the reason people wants to leave clinicals and want to do MBA and then wants to go healthcare management because they don't want to be burnout. Okay, so we are losing our healthcare providers because we don't have an ability to see the burnout causes patient safety issues. How do you monitor burnout? Anybody has done burnout monitoring? Nothing. Nobody knows the tool. How do I monitor burnout? Did I do any survey to check in my hospital that my staff is burned out? No way. Nobody knows. Come, work, take your salary, thank you. That's not what we want. We have patient safety issues. So, an example. We have a hospital which is experiencing medical errors and patient complaints. Hospital leadership starts to identify what is the reason. Reason is nothing but staff burnout. Okay, so nurses and residents are working long hours and leads to emotional exhaustion and work-life balance. This is important. So in UAE right now we have 4.5 days work, only 2.5 days is off. Some countries are coming 3 days a week, rest days off. I don't know what they're doing off, but that's a little bit too much. But again, coming to the number of hours to what you do is important. So reduce attention, fatigue, increased stress, and this is where the medication error happened. How many times we did medication errors but we don't report because we know that our job is left till something happens to the patient? We do that. But why can't we prevent it? Of course, it's difficult, I know. And that is where the burnout comes as a patient safety goal. I guarantee nobody is doing that except AACI. Okay, it's difficult to do it? No, you start on your own methodology. Get your people to talk about it. Simple, at least give us some data. What you did for this patient safety goal. Of course, there are technologies which can do it. I'm not talking about that. But can you bring change? You can start doing it. So what is the root cause analysis? The nurse was working too much. And if you see on the right side, the patient safety goal is actually related to burnout. So these are the symptoms of burnout. I don't know how many of you have these. I'm sure nobody will raise their hands. But if you go and check yourself, you will find from the HR, high turnover rate, people want to resign, slower response time, they don't come and they don't respond to the things that is required, they don't compliance with the protocols. This is all burnout, nothing else. So this is where we come up with whatever you want to do. Again, this is just a presentation to give you how you understand burnout. You can modify in the way that you want. One of the hospitals in Delhi, after they saw this standard, this is one of the requirements, it is again optional. They went the whole way to identify what is the tool, and they downloaded a 50 pages tool of how burnout can be assessed. And then they did the survey. They came to know that 55% of the hospitals have a burnout problem, but nobody reported it because nobody wants to lose their job. So can you understand that is how it is going? So improved patient safety, better quality. So can you see what I'm talking is patient safety systems, and these all are some of those that we never do. And this is where AACI actually brings the difference. Let's come to the clinical part of it. So governance is the governance person's job to do it. We also have patient rights, patient issues in standard from 11, which is clinical standards. So this is how it's used. So you use restraints. Do you admit psychiatric patients or no? Yes. Kerala is a little bit good, in North they don't admit. So suppose we use restraints and seclusion. We do different types. We put them on tying, we do chemical restraints, we do different models of restraints. And if you see a case here, the patient was psychiatric unit, they did a restraint, patient become physically aggressive, attempting to harm themselves and others, so you try to do a restraint concept. How many of you are trained on restraints? How many of you actually have a training given by an authorized person that how to use restraint? Only one? How to use restraint. That is where the most important things comes. I don't know how to do restraint. I just take a cloth and just put it on the hand and rails, whatever you want, and then make sure that the patient don't move and shout on them, right? So staff training compliance on restraint is one of the requirement of our standards. You should know how to restrain a kid. You should know how to restrain a mother, a psychiatric patient, or somebody who is having just a psychosis because he is in ICU. How many patients have ICU psychosis, right? So this is where we come. Why can't you use de-escalation techniques? So our standard says all of these, and how do you make sure that your clinical people come to these levels? Ethical and legal considerations. Some countries you can't restrain without, of course, there is a consent to restrain, and that is an ethical problem. If you ask me to stop moving and I wanted to see my mobile right now and you made me to restrain, you can file a case because you stopped my right to movement. At least you know that putting a side rail, do we put side rails? We do it for patient safety, the patient should not fall. But in US, they say that you put me under side rail, which means I cannot move. It's a restraint. Have you ever imagined it's a restraint? We don't consider that as a restraint. So it's a cultural problem, but I'm not telling to put that. I'm just giving an example on that. So restraint protocol, standard level 1113. We should have a team leader. How do you do that? What are the soft training? How do you monitor the patients? Our standards say specifically monitoring of restrained patients. Seclusion should be the last resort. And if you start doing the restraint, you should need to check whether our restraint policies are working. Suppose you are implementing this for the first time. I'm sure the policy may not be perfect. That is where ma'am was saying whether the patient is experiencing, what is patient experiencing when they put the restraint. You can change your policy. So every accreditation is working somewhere, which actually comes back to the same thing, patient safety, okay? So here we have a multidisciplinary meeting and the patient feedback. So this is where the restraint comes in. So I'm giving you 3 scenarios from governance, 1 from clinical, and the last one is physical environment standards, where we have entire mix of engineering things that becomes. So information security management. So anybody knows DPDP Act? DPDP Act. Come on, sir knows. This is a buzz in the market, you should know. And if I'm doing the survey and first question I ask the leadership, DPDP Act? If you say no, it's an NC, because you should be aware of an external influence which is going to happen in your hospital. Do you use medical records? Do you use apps for something to get the patient's report? LIS, RIS. You use maybe 15 things. I'm sure you will be using a lot of technologies. How do you make sure that you're not breaching it and that data won't go out of your system? Okay, this is the biggest problem all over the world. Everybody is getting hacked for the reason that you can make money in different channels. But our standard has one standard on information security. That's the last one. How deep you want to go depends on the surveyor. If a hospital has multiple things, I will take 2 hours to go deep into this to make sure they matches with our standards. So our standards is so open, it can be given to anyone who has minimal technology to the best technology in the world. We can scale it up as we want. So one of them is access control, information security management policy. I'll give you a good joke on this, and I have found somebody doing this. Access control, how many times do you use access control to enter into a room? Do you have access controls? Yes, entering into a pharmacy room, yes, entering into a lab or somewhere, wherever you want. So one of the times I was doing survey in one of the UAE hospitals, and I was in the ER, and I just told the office boy, the guy who just work around, and I said, just open this door for me. And he went, tick, 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 click, open the door. How he should have access? Is he authorized to have an access? No. I pulled up this NC, and you know what happens if you pull up an NC in a government and Department of Health. And by afternoon, the head nurse of that hospital in ED was terminated just because he shared his password to the office boy to get the things from inside during the night shift. Real example. I'm not making examples, okay? I think Swati was in the class. I told the same example maybe. Access control. Yep. So husband is keeping codes just because wife doesn't want to see. It's an access control. So it's an example where you need to make sure that your controls is with you. It's a real world example. What if I gave access to EMR? That's the case. So when people started using EHR, we don't blame. This is change management concept. People don't want to change. They want to make somebody assistant to do their job. That's great, but you cannot do with patient records. You cannot do with confidential documents. You need to do it because that's why you are paid for, right? We are not giving access to the sweeper on the ground because he's not allowed to do that. So see here, access control is one of our standards. The case is cardiology documentation was taken by the breach of because the nurse wants to make money from the press. Can be anything, you know, I'm just making stories. So what is here? Access control on EMR, access control on physical areas. That is where it happens. You know, 70% of the breach of data happens from inside people of the organization, not outsiders, because we are so much of, you know, outdated knowledge, no knowledge of how the people are going to hack you. And I'm sure everybody getting scammed at least some money over here, right? So that is happening. Personal scams, corporate scams, this is where we call. So access control is our standard. Access control to medical record, we detected a breach, we can detect it via automated alert. So suppose if I enter from an area which was not authorized, I can check my IP access and I can tell this person has an access from his home, which should not be allowed or can be allowed, whatever. How do you access your control protocols, staff training, compliance? This is where we come with, and regular audits. So why did I bring this? This is again patient safety. If you know DPDP Act, if you can go and check, the fine is up to 250 crores. Indian government is going to bring that. I'm sure it will not be the same, but up to 250 crores. So beware what is going to come. So we should be aware of what is happening with sort of breach of data, which is again patient safety, because I don't want to lose my data as such. So that's about patient safety systems of AACI. I just took few of them, which is important at this point where we want to deliver. I'm sure you are doing others with the NABH standards, of course, but some of the things are not yet in Indian hospitals, and that's where we make the difference. And how you want to do it, you do on your own, and we see whether you match to us. Thank you very much, and if you have any questions, you can pick it up.
Any more questions?
No questions means nobody understood anything, right? If you want to talk in Malayalam, I am okay. I am from Calicut, so you can talk in Malayalam if you want. What defines burnout? So that was there on the slides actually. So burnout is a subjective feeling the patient or person, it's not patient, it's actually person, right? So person starts to have, I don't want to go to the job today. I don't want to go. It's a reason of burnout. I am fed up after 7 hours of working, which I have a 12-hour shift. I am burnout with the alarms. I am burnout with documentation. Doctors are getting pop-ups in different areas because they are using different system. Burnout. So burnout is not one defined symptom. It depends on perception. So for example, if you ask me, my burnout levels will be different from Sir's burnout level because we have different experience and different way of doing it. Sometimes there's no other option. We just go with the burnout because I don't get a job and I don't want to lose a job. So we just go health with the burnout itself. So it's up to the hospitals to identify how do you see the physical signs of burnout. For example, physical signs of burnout, you cannot hide it, right? Dark circles, not in a mood, not smiling, not talking clearly, not in this world. You cannot hide it from anyone. It just comes up. Physiological markers. How many of you monitor your health and wellness? So yesterday I was speaking the same. We have a technology, I have a technology stuff also, so I'm just adding. We have a technology which reads 45 to 60 seconds of your face, and it can tell you BP, heart rate, and markers, even your glucose, without a machine. Can I use it for my burnout? Yes. That is the use case I identified after seeing the technology, that this is useful for doctors and nurses and my hospital staff to make sure that my patient is safe. But how many of you take the technology? I don't know.
Yeah, yesterday there was a discussion on the same subject in a different forum which said false urgency, excessive workload, no balance, toxicity, no recognition, monotonous work, lack of support, micromanagement, limited growth, unfair treatment, rental stage, low pay, pressure to perform, bad communication, and fuzzy expectations.
All of them. Any of them can happen. Some people show some will not show things. Right? You see that slide? That's the same thing. So I cannot put the slide. These are many things. Some example is just I'm not getting sleep. People are still on at 4 o'clock in the morning for no reason. Why? Burnout. I mean, I don't know what they're doing with that, but they are on mobiles. They are always burnout. So we don't have one single area to identify. We need to identify burnout from different areas.
But currently there is no assessment score which will be
There
able
is
to help.
assessment. There are international assessments for burnout tools. There are available methodologies. There are the ways to do it. I'm not talking about technologies, but there are subjective questionnaires. There are one-to-one interviews. There are surveys which can indicate your burnout levels. So there is tools available in the, of course, when you Google it, you will get it.
Thank you.
But we will not tell you which tool you should use. That is AACI. You should tell us which tool you want. And if we are happy with your tool and with your assessments and your outputs, good. You are doing something.
Just a question on AACI and JCI. How different is
Common
each of
question.
them?
I get this every day in and out. Okay. JCI is one of the best, I'm sure. They are gold standard. 150 years in service. I'm not telling that we can beat them, but we are different in the methodology. So what JCI does is, JCI's methodology is a prescriptive in the sense they want a copy-paste model to happen. For example, they want doctors to be, if you are a doctor, clinician, they want the doctor to check the patient at least 2 times a day. Mandate. I have put the standard, or not I, AACI put the standard as per the hospital's requirement. Suppose you want to check 10 times a day because he's VIP. You will do it. Okay, so there are differences where you can adapt your own methodology. I'm not telling what you should be doing, but whatever you are doing should match my standards. So if in fact, if you see really the JCI, we are opposite of JCI. That's the reason AACI is global in this sense, because most of the time people want to go JCI, they will ask first question, how much I should invest on my infrastructure, right? I told you, you can make a 5-star hospital, you can have people inside who doesn't know anything, you will not get accreditation. So you can have hospitals. I went to Georgia to do accreditations. It's not about how do you have the facility. That's not accreditation. People working there, the processes they have. Of course, infection control is a major NC in India because there is a problem with the cleanliness. But they have to keep doing. We are getting better, right? We were not the same as 15 years back. We are getting better. Everybody's getting better. So that's how we get it. So that's main difference between JCI to us is we allow hospitals to design their own process and match to us, not telling what you should do. One more example, I think a lot of people from physical environment were speaking. So generator requirement or power backup of JCI is minimum 30 minutes. Minimum. 30 minutes should be there. What if you are in UAE where there is no power cut? I have stayed 13 years, no power cut. What's the referral of that standard? What is the point of having that standard? Go to some other country which doesn't have a power and they need 12 hours of power backup. So why do I need to put a number there? You can have your own power backup concept, but it should match to your own requirements. Suppose this power cut happens, how do you manage your services? Show us the document, show us the drill, show us the evidence. That is where we differ from them. For JCI, you can show that I have these many things, I have a 30 minutes backup because my generator value output gives 30 minutes. For us, it's not enough. You need to tell how much you work and how you have designed it and how is your failures. So that's one of the difference. Rest are business, but I don't want to say. Again, we come every year, JCI don't come every year. It's a pain for some hospital to see us every year, but if you are on quality, you will welcome us every year because you want to show us what you changed in 1 year. And I have seen that in my 2 years that we went revisits. Some hospitals, we know that they're just for certificate because they don't want to improve. And that's the top hospitals in the India, okay? Some hospitals are so good, standalone, they studied the book like how we study for our entrance exam. The ma'am is sitting with me and lining everything and asking, how do I do this? And this is how they did. So put the effort, how much effort they have put on the standard to change themselves. So every year we see the changes. Thank you for that question.
Yeah, one more question. Quality Council of India came out with NABH and made it mandatory that all the hospitals will follow it, and then only insurances will have some credits and all those things. Any benefit from AACI?
Okay,
something
so
like that?
this question is again a operational business question, I will say. So what is the disbelief that we have? We have only knows two products. We only know NABH and we only know JCI. That's the disbelief. Both of them are ISQA accredited. We are ISQA accredited. ACHS from Australia is ISQA accredited. Canada is ISQA accredited. The rule says any ISQA accredited organization certificate is enough. It's not a mandate you need to have an NABH. But I have a huge respect for NABH because my 90% of the work is done by NABH. I don't need to worry about teaching them basic quality. I want to see the excellence in quality, excellence in operations. So we are not there to find out small mistakes that you didn't put a sign, the questions you asked in the morning. I can have 5 languages, do whatever you want. Do you make sense? For us, patient safety, rights and responsibility, you give a document to the patient. This is your rights and responsibility. That is what AACI wants. It's not you display. How many things are displayed in this room I have not seen at all in my eyes? You should give it to the patient. That's the patient rights and responsibilities. So your question was, is it accepted? It's accepted worldwide. It's just ISQA as the requirement. So because we are still growing, I know this is a problem that people ask. But go and check the document of CGHS requirements. What is the other one? EC something, right? There is another one. Yeah. Sorry, I don't remember those names. It is written ISQA accredited. So ISQA accredited means I give you 3 certificates of ISQA from us. We are ISQA accredited standard, ISQA accredited company, ISQA accredited training programs. More than enough.
Thank you.
Thank you, sir, for the question. Any other questions?
Thank you, Mr. Dheeraj Khatore, for your insightful session. Your expertise